Hi, very good morning, everyone. We are live on our weekly session from CMAAO. Today is 22nd of February, 2025. We are meeting at 9:30 a.m. in the morning, Indian Standard Time. Uh, Today we have a very important topic, uh, approach towards neonatal cholestasis. To talk about this, we have Dr. Sailen Kumar Bana. He is an associate consultant in the Department of Pediatrics, Gastroenterology, Hepatology, and Nutrition at Medanta, the Medicity, Gurugram. Sir, over to you.
Thank you, Shara, for your kind introduction. And before starting my presentation, I thank you to the office bearers of the IJCP and CMAO for giving me this opportunity in this international platform. So, to introduce myself, I'm Dr. Sailen Kumar Bana. I'm associate consultant in the Department of Pediatric Gastroenterology in Medanta, the Medicity, Gurugram, India. It's a 1,300 bedded JCI accredited hospital. Basically, we are dealing with the pediatric gastros, hepatos, and liver transplantations, basically. And we also deal with food allergies and other motility disorders in children. So, before starting my presentation, I would like to pay my gratitude to my mentor, Dr. Neela Mohan. She is presently the Senior Director and Head of the Department in the Department of Pediatric Gastroenterology in Medanta, the Medicity. And she is the President-elect National Indian Academy of Pediatrics for the year 2025. So let's start the topic without further delay. So today's topic for the discussion is approach to neonatal cholestasis. So to start with the definition, so the cholestasis is defined as reduced bile formation or bile flow, which results in retention of the biliary substances within the liver, which are normally excreted into the bile and which are destined for the elimination into the intestinal lumen. So basically, cholestasis has three components to diagnose a case of cholestasis. First is jaundice. The second one is dark color urine, which stains the diaper with or without clay-colored stools. So the definition of neonatal cholestasis is it refers to conjugated hyperbilirubinemia in a newborn or infant with passage of high-colored urine with or without clay stools. So how do we define conjugated hyperbilirubinemia? It's defined as direct bilirubin more than 20% of the total bilirubin, or the direct bilirubin fraction is if the absolute value is greater than 1 milligram per deciliter. So are the cholestasis and hyperbilirubinemia, are these terms are synonymous? No, definitely not. These are not synonymous. So basically what happens is during the phase of cholestasis, the normal acid flux, and the conjugated bilirubin, which are normally excreted into the bile and subsequently to the duodenum. This bile acid flux and excretion is getting hampered during the phase of cholestasis. So, a central feature of the conjugated or direct hyperbilirubinemia is a practical and clinical marker and surrogate marker of cholestasis. So, though these terms are not synonymous, but still we use conjugated or direct hyperbilirubinemia as the surrogate marker of the cholestasis. So, can I know without any testing whether my child is having direct bilirubinemia? Yes, we can predict it. If the urine stains the clothes or the diapers, then most probably the child is having conjugated hyperbilirubinemia. Now, another important thing to consider is the stool color. So this is the Taiwan stool card. As we see, there are six gradings starting from 1 to 6. So 1, 2, and 3. These stool colors are abnormal and they suggest cholestasis. And the normal stool colors are depicted in the column of 4, 5, and 6. What can be the etiology of the neonatal cholestasis? The etiology it's a very broad spectrum. The pathology may lie within the hepatocytes and within the biliary ductules. So the biliary ducts, the bile ducts may be intrahepatic or extrahepatic. So the main pathology which leads to intrahepatic cause for the neonatal cholestasis is paucity of intrahepatic bile duct, which might be syndromic like Alagille syndrome, or non-syndromic like prematurity, many of the viral causes, alpha-1 antitrypsin deficiencies, and some of the idiopathic causes. The extrahepatic, that is the structural and obstructive causes. There are few common causes like biliary atresia, choledochal cyst, and inspissated biles, which may lead to cholestasis due to the structural or obstruction of the bile flow. And there are several hepatocellular causes also. So in several Indian studies, it is found that approximately 53% of the cholestasis is attributable to the hepatocellular causes, and the rest are either due to the biliary atresia, which contributes to approximately 34% of the neonatal cholestasis, followed by extrahepatic biliary obstructions like choledocholithiasis, and paucity of intrahepatic ducts contributes to 3% of the hepatocellular causes. So the hepatocellular causes, the most important causes are neonatal hepatitis, various metabolic disorders, and some other causes. 2% are some due to some other causes. So what are the various hepatocellular causes? The first and foremost important thing to consider is infections like sepsis, urinary tract infections, Stauch infections, several viral causes like herpes and adenovirus and malaria. Different type of metabolic causes which may affect parenchyma of the liver like galactosemia, tyrosinemia, storage disorders, mitochondrial disorders, paroxysmal disorders, and hereditary fructose intolerance and cholesterol storage disorders. There are different type of genetic causes also like progressive familial intrahepatic cholestasis, bile acid synthetic disorders, Alagille syndromes, neonatal hemochromatosis, and neonatal intrahepatic cholestasis, which is caused by certain deficiencies. Other endocrine causes are like hypothyroid, idiopathic causes, and hypopituitarism. Some of the miscellaneous causes like use of the total parenteral nutrition for more than 2 weeks, mainly the soy-based TPNs, they cause neonatal cholestasis. Other causes like Down syndrome shocks and septic shock, hypoperfusion, and some other toxic causes also leads to this important disease. There is a terminology called idiopathic neonatal hepatitis, in which, despite of extensive investigations, we are not able to find any kind of the causes. So we label the child as having idiopathic neonatal hepatitis. So whenever we get a case of neonatal cholestasis on the basis of three components, that is jaundice, the urine which is staining the diaper with or without clay colored stool. So our child, so we suspect that the child might be suffering from the neonatal cholestasis. So first thing we need to look is acholic or fluctuating color stools. Whether the stool color is fluctuating means sometimes pale, sometimes yellow, or acholic like some most of the times pale color stool. So the causes of neonatal cholestasis in a well child with fluctuating stool colors, there are four DDs. First disease is biliary atresia, second is biliary atresia, and third is biliary atresia. The fourth DD is other causes like Alagille syndrome, TPN associated cholestasis, neonatal sclerosing cholangitis, few cases of the choledochal cyst, and PFICs. So the stool color of the child is pigmented, that is not white color stool. If the stool color is pigmented, then we'll need to see whether the child is a well child or the child is sick child. There are two broad categories. If the child is a well child and is feeding well, thriving well, there is no signs of the sepsis, then there are some treatable causes like hypothyroidism, PFIC, cytomegalovirus infection, and NICCT. If the child is a sick child, then the child is probably having some form of the infections like sepsis and UTI, or the liver is probably decompensating due to the metabolic liver diseases like galactosemia, tyrosinemia, HFI, mitochondriopathies, PFIC, and hypopituitarism. So let's come to two case scenarios. So we got a child who was 52 days old, female child, term appropriate for gestational age. He started to have jaundice since day 8 of life, which is gradually progressive. The stool color is fluctuating, most of the times alcoholic stools, and the child is having jaundice, dark urine with diaper staining. The child is also having intermittent skin bleeding, which is responsive to the vitamin K. This is the stool color of the child. There is no history of fever, lethargy, refusal to feed, anemia, or TPN use or growth failure. This is the stool color of the child depicting the alcoholic stools. On examination, the child was having icterus. There is no facial dysmorphism. Three stool colors were found to be alcoholic. The abdominal examination showed a 4 centimeter liver below right costal margin with a spleen of 2 centimeter. CVS is normal. So this present case, the child is having dark urine with diaper staining, which indicates the child is having conjugated hyperbilirubinemia. The child is also having alcoholic stools. So the cause of the conjugated hyperbilirubinemia was mostly due to the obstructive or structural pathologies. Bleeding is vitamin K responsive. So mostly the child is having cholestasis. There is no perinatal events. There is no TPN use or anemia, which rules out the TPN associated neonatal cholestasis and inspissated bile. On examination, the child is having firm liver with splenomegaly, which indicates portal hypertension. So, few things I need to stress in this slide is in every cases of the neonatal cholestasis, always examine stool color, that is consecutive 3 samples. We need to try to find out any kind of facial or other dysmorphic features. We should also do an eye examination to see whether there is any cataract or vitamin A deficiency, posterior embryotoxin, and we also need to see the fundus to look for the cherry red spots, chorioretinitis, drusen, and often of hyperplasia. Also try to examine the skin for the pruritic marks and CLD stigmata and the genitals. So these are the investigations of the child. We showed direct bilirubin of 13, the total bilirubin of 13 and direct fraction of 9.7. His INR was initially 1.8. After giving a dose of vitamin K, it came down to 1.2. So is there any role of imaging in this case? Yes. So present in this present case, we did an USC abdomen. We showed a 7.4 centimeter liver, which is coarse in ecotexture. Gallbladder is not visualized, CBG is not visualized, and spleen is 8 centimeter. However, there is no ascites. So this gives us a clue towards the biliary atresia because the GB is not visualized. The clinical features are suggestive of obstructive cause of the conjugated hyperbilirubinemia based on the dark urine, alcoholic stools, and jaundice. So in case of the biliary atresia in USC, we get some important features like non-visualized GB or small GB less than, which is less than 15 millimeter, that is 1.5 centimeter. If you get a triangular cord sign, there is poor contractility of the GB after feeding the child. There is increased hepatic artery diameter and soft capsular flow also. In case of the choledochal cyst, we will get dilated CVDs with or without dilated intrahepatic biliary radicals. So this is a picture showing a triangular cord signs. Basically, it's a 4 millimeter thick fibrous cord which we get along the anterior wall of the right portal vein on the oblique longitudinal scan in the USC. And this triangular cord, it represents the fibrous ductal remnants of the extrahepatic bile duct in case of the biliary atresia. So is there any role of the hydascan in this scan? Yes, there is some role of the hydascan in this case. So basically, in hydascan, we inject a dye through the vein of the child, and we see the hepatic uptake and biliary excretion of this child. Like this picture shows a normal hydascan. Like we see this white marks, they indicates the hepatic uptake, and White mark indicates the intrahepatic ducts. Subsequently, the dye is passing through the common bile duct. Then the dye is being uptaken by the gallbladder, subsequently to the duodenal C loop and small bowel. So this is a normal HIDA scan in which the dye is being uptaken by the liver normally, and the dye gets excreted to the small bowel loops. But in our case, the HIDA was non-excretory, like we can see. Though there is hepatic uptake, there is no uptake or excretion seen in duodenum or gallbladder. So this is a non-excretory hydroscan in our case, which is again suggestive of biliary atresia. So hydroscan does not basically provide any extra information beyond what is provided by a alcoholic stool. It just tells that the dye is not being extruded through the bile ducts. And the alcoholic stool also indicates the same thing. So hydroscan does not provide any kind of extra information. It has very low specificity, and it delays the diagnosis and subsequent surgeries because it needs priming by phenobarbital for 5 days prior to performing the examination. So in the modern day practice, there is very limited indications of the HIDA scan, and we use the HIDA scan where the liver biopsy is not available or equivocal changes if we get equivocal changes in the liver biopsy. So in only in these cases, we use the HIDA scan. Again, there are some limitations with the HIDA scan. There might be false positive scans in case of the in patients with interlobular bile duct paucities, idiopathic neonatal hepatitis, and low birth weight babies, though false negative results are extremely rare. Is there any role of liver biopsy in this case? Yes, definitely. The liver biopsy is 90 to 95% accurate in diagnosis of the biliary atresia. Along with the diagnosis, it has also a prognostic role, and it guides the treatment as well. So why the prognostic role? If we, in case of the in the liver biopsy, if we advanced fibrotic stage like F4 or F5 fibrosis stage, then we primarily counsel the parents to be prepared for the subsequent liver transplantations because the bile flow rate after a Kasai potentoscopy might not be successful in case as compared to the cases in which there is a low grade fibrosis. Along with diagnosis of the biliary atresia, it also rules out the alternate causes of the neonatal cholestasis like Alagille syndrome, TFIC, neonatal sclerosing cholangitis, and CMV. So the liver biopsy we can perform through three routes, that is percutaneous route, second is transjugular, that is transvenous route, and the third one is laparoscopic route. There are few important recommendations for the percutaneous liver biopsy. Before performing a liver biopsy, we need to check the INR and platelet counts of the child. If the INR is greater than 1.5 or the platelet count is less than 60,000, then we need to do a then we need to do a sonoclot or PEG. Then we need to decide on transfusions and correcting this coagulopathy before performing a liver biopsy because there is always chance of a bleed in case we are doing a liver biopsy in the state of coagulopathy. So another important thing is to consider is ascites because the neonatal cholestasis cases, especially the metabolic cases and the children with biliary atresia who present in the latter age, they get decompensated and we many a time we get cases of ascites in these cases. So if the patient is having ascites, we need to drain it through a catheter prior to performing a liver biopsy. Or if the child is too sick and drainage is not possible, then we can go through the transjugular liver biopsy. So these are the clinical pictures of the liver biopsy which we got in our case. So there was distorted acinar architecture with the bridging fibrosis, expanded portal tracts, ductal proliferations, and canalicular bile plugs. All these three features are pathognomic of the biliary atresia. There is a histological scoring system for the biliary atresia. and there are different components which the histopathologists use for the diagnosis of diagnosis of the biliary atresia. So in this scoring system, higher the score, the more likely is the case to be biliary atresia. So another important differential diagnosis of the biliary atresia is neonatal hepatitis, but in the liver biopsy, the liver biopsy picture is completely different from the biliary atresia. In case of the neonatal hepatitis, we get lobular disarray and inflammatory cells in the portal tracts. Bile ducts, they show little or no alterations, and giant cell transformation is a prominent features in case of the neonatal hepatitis. Another important entity is Alagille syndrome, where we get the doctopenia pattern, in which the interlobular ducts to portal tract ratio, the ratio drops down to less than zero point 0.9 in case of the full-term infants and less than zero point 0.5 in case of the older infants. So normally, what in the normal state, a portal tract contains hepatic artery, portal vein, and bile duct. But in case of the Alagille syndrome, the bile duct, which usually resides along the side of the hepatic artery, they get missed. So the interlobular duct to portal tract ratio, it drops down. In case of the alpha 1 antitrypsin deficiency, we get PAS positive and esterase resistant granules along with the pseudoacinal rosity. So the gold standard for the diagnosis of biliary atresia is a cholangiogram, which might be intraoperative or percutaneous cholangiogram. These are the clinical pictures of our patients. The first one shows a proximal and distal patency, means the intrahepatic ducts along with the extrahepatic ducts till the common hepatic duct are patent, along with the CBD, along with the patent CBD and a patent gallbladder. The second picture shows a type 2 biliary atresia in which the distal portion is patent, that is the CBD is patent, but the proximal, the common hepatic ducts are not patent. And the third one is shows a type 3 biliary atresia in which there is complete obliteration of both proximal and distal bile ducts. So what is the management? Kasai portoenterostomy is the definitive management for biliary atresia. To highlight one thing, earlier the treatment, the earlier the age at the Kasai portoenterostomy, better is the prognosis. There have been several studies from USA, Canada, France, and United States, along with some Indian studies also. They show that earlier the child undergoes the Kasai portoenterostomy, so more is the 2 year, 4 year, and 5 year transplant-free survival and overall survival rate. So in our case, after performing a Kasai portoenterostomy, 4 weeks post-operative, the bilirubin has dropped down to 1.6 and the stool has become pigmented. So the final diagnosis is biliary atresia post Kasai portoenterostomy, and it is a successful post Kasai portoenterostomy. So this slide I have already highlighted. So to again highlight, in case of the neonatal cholestasis, we need to see the stool color. If the child is a well child with a fluctuating stool color, most probably the child is having biliary atresia, and we need to speed up the things, perform a Kasai portoenterostomy. So this is the second case scenario. So we got a 3.5 months male child, with a birth weight of 2.3 kg. So he was small for gestational age. He started to have jaundice since day 10 of life with a high colored urine. But in this case, the stool was not alcoholic. The stool was pigmented. Along with the jaundice and high colored urine with a pigmented stools, he is having progressive abdominal distension suggestive of ascites since last 3 weeks. The child is not accepting the feeds. The child is refusing the feeds, having fever, lethargy, suggestive of sepsis, and the child is not gaining his weight adequately. The present weight is 3.3040 gram at the age of 3.5 months. There is no history of bleeds, seizures, altered sensorium, diarrhea, vomiting, or extrahepatic involvement. There is a history of third consanguinity. And on examination, we got a 3 centimeter lever below right costal margin and with a span of 7 centimeter with a spleen of 2 centimeter below left costal margin and along with ascites. There was no dysmorphic features in our case. And on eye examination, we got bilateral cataract. So to summarize, this is a case of neonatal cholestasis with pigmented stools. Is a sick child with failure to thrive, with features of sepsis, with family history of consanguinity or sibling death, with cataract, and the child is on breastfeeding. These are his investigations, which are suggestive of a coagulopathy with INR 2.6, bilirubin is 6.7, and the direct fraction is 3.4 with albumin of 1.8. So the lab investigations are also suggestive of decompensation, hepatic decompensations. Right. So is a sick infant with pigmented stools, which is suggestive of neonatal cholestatic, most probably intrahepatic or hepatocellular cause. The ascites, hypoalbuminemia, and coagulopathy, these are suggestive of synthetic dysfunction. The family history of recurrent abortion, consanguinity, vomiting, diarrhea, lethargy, and seizures. We need to think of the metabolic liver diseases. So, what are the red flag signs of the metabolic liver diseases? There should be history of consanguinity, aversion, and previous sibling death. The child might be having failure to thrive, diarrhea, and vomiting. Recurrence during the period of catabolic stress, suggestive of fatty acid oxidation defect. So convulsions, early morning irritability, lethargy, developmental delay, hypotonia, and cataract are suggestive of galactosemia. Rickets and renal tubulopathy are pointers for the tyrosinemia and hereditary fructose intolerance. Hypoglycemia, lactic acidosis, hyperammonemia, aversion to sugar or proteins are also indicative of metabolic liver diseases. So whenever we are assessing a child with neonatal cholestasis, we need to see these red flag signs which are suggestive of metabolic liver diseases. So how to evaluate a sick child with neonatal cholestasis? So the first step is we need to do a metabolic screening. Second step is to do a sepsis screening and other tests are like plasma cortisol level. So the test for the non-glucose reducing substance are Benedict test and urine for glucose by dipstick. So the precaution is the cleanse is the child should be on regular galactose or fructose diet before performing a Benedict test. The second step is we should go for the definitive test like GALT assay for galactosemia, urinary succinyl acetone for tyrosinemia, plasma TMS, tandem mass spectrometry, and urine GCMS to rule out aminoacidurias and organic acidemias. The GALT assay, we should perform the GALT assay before giving the PRBC transfusion and we need to send the urine for the urinary succinyl acetone in ice and it should be processed within very few hours and the final step for the diagnostic evaluation of a sick child with neonatal cholestasis is whole exome sequencing. Our present case we got urine reducing substance positive with a GALT level of only 5 units per gram of hemoglobin. The normal GALT level should be more than 15 units per gram of the hemoglobin. So we instituted a lactose-free feed for the child, and on 4 months follow-up, the jaundice resolved, the growth pattern resumed, the cataract is still persistent. So this is the diagnostic algorithm which Indian Pediatrics has adopted in the year of 2014. So basically, this algorithm suggests that we need to hurry up in the diagnosis of biliary atresia and in the management of the biliary atresia, because if the child crosses the day of life to undergo a Kasai port enterostomy, then we need to uh, put the child for the transplant liver transplantation list. So if the child's age is more than 90 days with ascites, or the child's absolute age is greater than 120 days at the time of presentation, we need to refer the child for the liver transplantation center. So nutritional management is one of the important component in case of the management of the neonatal cholestasis. These children, they require a high calorie requirement with 125% of the recommended daily allowance based on the ideal body weight. In breastfed infants, breastfeed should be continued. We should also give medium chain triglyceride MCT oil with a dose of 1.2 ml per kg per day, 2 to 4 divided doses. It has to be mixed in expressed base milk, basically. And adding the puffed rice powder or the MCT to the milk, it can increase the energy density of the feed. The essential fatty acid component should be 2 to 3% of the total energy provided. The vegetable protein should be given at a dose of 2 to 3 gram per kg per day. Vitamin supplements should be continued till 3 months after resolution of the jaundice. And the special infant formulas and diets are recommended for the children with specific diagnosis like galactosemia, fructosemia, and tyrosinemia. We have different diet patterns and different formula fits for this metabolic disorders. This is the recommended dose of the vitamin supplements. We need to supplement the child with vitamin A, D, E, K, along with water-soluble vitamins, along with other minerals like calcium, phosphorus, zinc, magnesium, and elemental iron. Another important step of management is management of the pruritus, because due to the cholestasis, many of the child, they start to have pruritus after the age of 6 months. So the order should be the orthodeoxycholic acid at a dose of 20 milligram per kg per day, followed by rifampicin at a dose of 5 to 10 milligram per kg per day, followed by phenobarbital at a dose of 5 to 10 milligram per kg per day. The symptom chart should be made for the pruritus, and the definitive management is the surgical management, like I have already highlighted, Kasai potentiostomy for the biliary atresia, external and internal biliary diversion for the progressive familial intrahepatic cholestasis who are without any decompensated cirrhosis features, excision of the choledochal cyst. In case of the choledochal cyst, it may need a simple excision of the choledochal cyst or left lobe or left lateral lobe hepatectomy, depending on the extent of the involvement of the choledochal cyst. And in cases of the decompensated case, irrespective of the etiology, might it be biliary atresia, choledochal cyst, might it be Alagille syndrome or metabolic liver disease, then we need to go for the liver transplantation of the child. So this is our experience with the liver transplantation. So we are a JCI accredited hospital. Our department primarily deals with the liver transplantation of the small kids, starting from the newborn period to 18 years of the age. So in our department, total 4,500 liver transplantation has been performed by the team, and among this 4,500, total 500 pediatric liver transplantations have been performed so far. 30% of the children who undergo transplantations are very small kids with a body weight of the less than 8 kgs. The smallest liver transplantation was of the world was performed in our hospital. The weight of the child was 2.1 kg, and we have a extremely good outcome of 90% survival rate at the 5 years of the liver transplantation. So this is our experience. We performed nearly 500 pediatric liver transplantation. The most common cause for the liver transplantation was CLD, which accounted for approximately two-thirds of the cases of the total children undergoing liver transplant who underwent liver transplantation. The commonest cause of the CLD was biliary atresia in our pool, and the commonest cause of the metabolic liver disease was Wilson's disease and tyrosinemia combinedly. So this is the breakup of the CLD. Like I said, the most common cause of the CLD was biliary atresia, which accounted for near about two-thirds, that is 70% of the total CLD cases. The other CLD cases were Caroli's disease, Budd-Chiari syndrome, autoimmune hepatitis, congenital hepatic fibrosis, sclerosing cholangitis, and other cryptogenic causes as well. Out of the total 500 liver transplantation, the biliary atresia cases were near about 150. And among this 150 cases, 65% underwent prior caseipotoenterostomy, who subsequently required liver transplantations. And around 35% cases did not underwent prior caseipotoenterostomy. So, like I said, in our institute, the survival rate is and the outcome rate is extremely good, with the overall survival of 91%, with 1 year survival of approximately 95%, and we analyze data with a follow-up of mean follow-up year of 8 years. So the take-home points from this discussion are whenever there is a jaundice in newborn beyond the first 2 weeks of the age, ask for the total and direct bilirubin. Neonatal cholestasis is conjugated hyperbilirubinemia with greater than 20% of the total bilirubin. If if we get the cases of neonatal cholestasis, we will have to do basic blood tests like liver function test, INR, post vitamin K, CBC, CRP, urine routine, urine reducing substance, TSH, and blood sugar. This helps to rule out the treatable causes like sepsis, urinary tract infections, hypothyroidism, and galactosemia. We need to do a stepwise workup after detailed history and examination. And this is the key in case of the evaluation of neonatal cholestasis. Classify the causes based on the stool color and decompensations. Identify whether the patient is sick or not sick. This is one of the most important steps in the evaluation of the neonatal cholestasis. If the patient is sick, then we need to think about the infections, sepsis, and metabolic causes. If the child is not sick and is thriving well, then we need to see the stool color, whether the stool color is alcoholic or fluctuating. Then we need to think about biliary atresia and we need to evaluate accordingly. If the stool color is pigmented, then the causes might be PFIC, cytomegalovirus infections, and Alagille syndrome. USC is the first screening test which need to be done both in the fasting and postprandial state to evaluate the gallbladder and bile ducts. Yes, sir. It also gives information on the liver, spleen, ecotexture, any features of the CLD features, and along with the presence or absence of the ascites. Liver biopsy is the most informative tool in the experienced hands. Hydroscan needs priming for 5 days by phenobarbital, and basically it is required in patients who present late who present late and there is no indication of the hydra scan. We can straight away go for the other diagnostic modalities like USC and liver biopsy. So in the modern day practice, hydra scan doesn't have much role, and it has also low specificity. So early referral is the key, and before giving referral to a pediatric gastroenterologist or a transplantation center, we need to start vitamin K at a dose of 1 milligram per kg, phenobarbital at a dose of 5 milligram kg, and ostrodeoxycholic acid along with at a dose of 15 milligram per kg per day. And after giving these three medications, we need to refer the child to the specialized center, to a pediatric gastroenterologist or hepatologist for the further evaluation and management. Thank you so much. So this concludes my topic of presentation. Thank you. Hi, Saurav and Dr. Akhtar. So I have completed my presentation. So
Thank you, sir.
No,
Thank you for a wonderful presentation and
thank you so much.
very insightful and very knowledgeable for
no,
our.
Sarab, thank you so much, Dr. Sailen. It's an excellent presentation. In fact, you have covered most of the neonatal issues. There's nothing you have left on your presentation. I have few question like how early one can diagnose? What is the role of fetal-maternal medicine intrauterine diagnosis of obstetric jaundice or cholestasis? Is, are there work going on, or is there any diagnosis they are doing on that? Second question is Down syndrome. You mentioned. Can you just highlight how early, how late Down syndrome present with the obstetric jaundice? And have you seen, or maybe, and Gilbert syndrome? What age they usually present? And I haven't seen any case like that. And yeah, those are the concern. Thank you.
Okay. So, coming to the first point, what is the role of fetal-maternal diagnosis? So, like I said, sir, there are few cleanses with points for the metabolic liver diseases, like if there is prior history of consanguinity or a prior history of sibling death, early neonatal death due to the jaundice or decompensation features, then we need to assess for the next pregnancies. So we can the mother can undergo amniocentesis, and we can go for a whole exome sequencing whether the this child is having any kind of metabolic liver diseases or not. Along with that, the prenatal ultrasound, it has a good sensitivity of catching up the cases of choledochal cyst. Although the biliary atresia, the triangular cord signs, these are very difficult to appreciate in a prenatal ultrasound. But in case of the syndromic biliary atresias, like we get the two types of biliary atresia, that is non-syndromic and syndromic. In case of the syndromic biliary atresias, other associated features like duodenal atresia, congenital heart disease, these are associated with the syndromic biliary atresia, which can easily be picked up in neonatal in a fetal ultrasound. And in case we get any kind of this abnormality after birth, we should be very careful to look for the features of the neonatal cholestasis. So the second question is Down syndrome. Yes, Down syndrome is associated with biliary atresia. Down syndrome is also associated with metabolic liver diseases, though there has not been various studies which say that the biliary atresia, the incidence of the biliary atresia is more in case of Down syndrome. There has been, as per my knowledge, as per the literature search, I could not find any study which says that biliary atresia is more common in Down syndrome. But in case of the Down syndrome, whatever cases we got syndromic biliary atresias. So in those babies, along with the biliary atresia, there are other associated features also. Like we got a case with who underwent duodenostomy due to the duodenal atresia on day 2 of life. Subsequently, he developed jaundice after 1 month of the age, and we diagnosed him as a case of biliary atresia at 45 days of the life, and the child is scheduled for a cyphotoenterostomy in next 1 to 2 days. So definitely biliary atresia has can be associated with Down syndrome along with other extrahepatic features.
There is a question. In case of delay diagnose, is it fully curable or can it be a problem?
So the delayed diagnosis. If you are asking about biliary atresia, the clinch to the diagnosis and management is early diagnosis. If the child develops fibrotic features in the liver, if the child develops other decompensation events, then we will have to straight away proceed for the liver transplantations, because in these cases, the Kasai photoenterostomy after Kasai photoenterostomy, the probability of establishment of a full bile flow significantly reduces as compared to the earlier diagnosis. Like I highlighted, We have done transplantation in approximately 150 cases of the biliary atresia with a 5-year survival rate of approximately 91%. So survival rate is definitely good considering the management is, if the management is being done at appropriate time. Definitely delayed diagnosis as a poorer outcome.
Normal human being, for a normal non problematic patients, do they have to get it diagnosed, like in terms of the mothers or in terms of the expecting mothers? Do they have to diagnose something, some testing or something to rule out?
Routine screening is not required, sir.
Not required.
So
Okay.
routine screening is not required. So we can simply identify whether the child is having cholestasis or not by using the Taiwan stool color chart. There are 6 stool colors, like I have already highlighted. So this is the, let me show you again. This is the Taiwan stool color. By
Yeah.
simply looking at this stool color, if the pattern of the stool color lies in between 1, 2, and 3, then definitely there is some problem and we need to investigate. We do not need any kind of the maternal screening, because even if we do a maternal screening, we do not have any we are not going to do any kind of any intrauterine intervention. Whatever intervention will be required after birth only.
So do we have any other questions on the floor? Dr. Naidu, Dr. Prakash?
No questions.
Great. So, sir, with this note, I think we would like to end the session. We are right on time with the session. So, I humbly thank you for your time and efforts which you have made for giving us knowledge about this topic. Thank you so much for presenting on CMAAO. With this note, we would like to end the session, sir.
Thank you so much for the for giving me this opportunity to present this case and this to discuss this important topic in this platform. Thank you, the organizers of the CMAAO and IJCP. Thank you so much.
Thank you so
Thank
much. Thank
you.
you.
Thank you.